Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone. Hello everybody. Welcome in Egypt. Welcome in Cairo. Welcome to you all. I'm really blessed to be here on the stage, exchanging knowledge and experience between you all. Welcome, Dr. Fathi. Please come in. Now I would start this session, which is made to be on skull-based osteomyelitis. I will invite Professor Dr. Hisham. Okay. To present his first presentation about imaging in skull-based osteomyelitis. Please do. Would you adjust the presentation?
For Dr. Hisham. No, they get what? Got حاجة زي البوكس. لا.
One.
هاتك. حرب أصلك.
Good afternoon. Thank you, Mr. Chairman. Really, this is meant to be an instruction course, 30 minutes, but I have to reduce it into 10 minutes. Imaging for necrotized otitis externa, the changing paradigm. We know that pathologically, necrotized otitis externa is a severe, aggressive type of infection with tendency to spread anteriorly and medially to involve the neck spaces of the neck and intracranially. To confirm the diagnosis of necrotized otitis externa radiologically, we have to document the presence of three findings. Number one, the presence of otitis externa by CT, and here be aware of wax, which may appear as granulation on CT, and may have restricted diffusion, suggesting cholesteatoma or neoplasm. The second thing, we have to document the presence of periosteal bone erosion, which occurs on the outer periosteal surface of the temporal bone of the mastoid. And this has to be differentiated from diabetic mastoiditis with facial paralysis, where bone erosion occurs in the inner endothelial layer. The third is to document the presence of soft tissue infection. Actually, there is no single imaging modality which can show the three abnormalities together good. So a combination of modality is usually required. Common imaging modality are CT, MRI, and nuclear medicine. CT is best for bone erosion. MRI for soft tissue. It is soft tissue evaluation, bone marrow changes, and intracranial complication. While nuclear medicine is reserved in cases when CT or MRI are not diagnostic. Here, the technician bone scan and the gallium scan are done together. If both are positive and the gallium showing larger activity area, this is very suggestive of necrotized otitis externa. Gallium scan can follow disease progression and resolution. CT, with or without contrast, depending on the kidney function of our patient. It has to be sublimetric, 0.6, in order to able to show the small erosion. Bone window usually may give a false negative result in about 40% of cases, in early cases, because at least about more than 30% of bone mineralization has to occur in order to show up in the CT. This means in early cases we have to reveal the CT if it is negative. It fails to pick up progression and is not suitable for termination of treatment as signs persist for months after resolution. But to evaluate the soft tissue by the CT, we have to give contrast. which can show obliteration of the fat planes and can document the presence of abscess. In some cases, we might resort to have angiography, CT angiography or venography if there is vascular complication such as stroke or cavernous sinus thrombosis. MRI is best for venodic soft tissue and can show bone marrow changes early in the form of low T1 signal replacing the normal fat with heterogeneous enhancement and increase the two signal involving the petrous apex, sphenoid bone, and occipital bone. Actually, abnormal signal persists up to 12 months. So it is not suitable for decision to terminate treatment. If we give a contrast, we can differentiate between cellulitis and abscess formation, when cellulitis has heterogeneous enhancement, but abscess has a rim enhancement. Conventional MRI is unable to differentiate between ongoing active infection and the post-inflammatory fibrosis and granulation tissue, which can persist also for years, for about 1 year, and it's not suitable for decision to terminate treatment. Technetium scan is very sensitive for bone affection, but not specific for the cause. It can be seen in malignancy after trauma, prior history of ear surgery or mastocytitis. Cannot differentiate between active bone inflammation and remodeling and reformation when bone is healing. So it remains abnormal even after satisfactory treatment. Gallium white blood corpuscle scan is how much very specific for the infection, can monitor disease resolution, but has low anatomic resolution. Generally, traditional nuclear medicine are problematic. Availability, not available in many centers. 48 hours delayed imaging. Interpretation expertise is required. Additional costs. Some limitation in the safety and the specificity. So to overcome some of these, a hybrid technique was advised by combining the nuclear medicine with either CT or MRI. This increases the sensitivity of the technique and have better anatomical localization. Actually, there are two game changers in the radiology of necrotizing otitis externa, which is the PET scan and the diffusion-weighted MRI with ADC map. Hybrid technique increase sensitivity with the best sensitivity is achieved by the PET scan, which reaches about 96%. PET scan has replaced conventional technetium and gallium scanning. It is widely available, short scan duration, higher spectral resolution, and by calculating the standard uptake value, we can use it for evaluation of treatment response, for decision for cessation of medical treatment, and has reported to be able to differentiate between fungal and bacterial infection. Diffusion-weighted image, this is another, the second game changer. It depends on detection of the motion of the motor molecules. If restricted, it gives a bright signal. The causes of restriction are infection, infarction, abscess, tumor, and autoimmune disease. Diffusion-weighted image can differentiate between abscess and necrotic tumor, cholestoma, granulation tissue, chondrosarcoma, and chondroma. And by calculating the apparent diffusion coefficient, we can differentiate between malignant tumor from infection when malignant tumor has a lower ADC value than infection. Actually, active infection generates a high signal on the ADC map. Diffusion-weighted image has the following advantage. No contrast is needed. So it is suitable for patient with poor kidney function. And also in patient with necrotizing otitis externa are very fragile, and we can avoid very susceptible for contrast-induced nephropathy. There is no radiation, putting in mind that in this disease, repeated imaging is required. It is widely available and cost-effective. Diffusion restriction confirm an abscess formation when a contrast is contraindicated by having a high diffusion-weighted signal and low ADC map signal. In this case, this is indication for surgery. Also, ADC mapping values can differentiate between malignant tumor and the infection, externa, when higher ADC value are seen in necrotizing metastasis externa than those in esophageal carcinoma or lymphoma, which is another cause indication for surgery to take a biopsy. It is also superior for the differentiating active inflammation from residual fibrosis. And so it is more suited for monitoring treatment response and guiding treatment termination. Diffusion weighted imaging, our protocol, we do the diffusion weighted restriction at initial examination and initial diagnosis in order to make the test more sensitive and to act as a baseline for follow-up. And then we repeat it every 4 to 6 weeks to confirm the occurrence of improvement response to medical treatment and or to detect a complication like an abscess. And after normalization of the clinical and the biomarker marker like CRP and the ESR for weeks, we do it in order to take the decision to terminate medication. And even after that, at 6 weeks and 3 months, we repeated those clinical resolution of infection in order to detect early relapse. Relapse are common in this disease. It's about 20 to 25%. They have to be relapse. Can I have just 1 minute? Can I have 1 minute? This is an example. We can see in T1 low signal suggesting necrotizing externa, and which was high ADC value in the top, and the bottom, this is after treatment. There is complete disappearance of the resolution in the ADC map, which you can guide out for to terminate the treatment. And our protocol is to do CT and MRI. We advise diffusion weighted imaging MRI with gadolinium and fast separation. Nuclear medicine is also reserved for undiagnosed cases. In this case, we order PET scan. Long-term monitoring, the soft tissue finding is the best radiological indication of improvement. Decision to stop medication depends on clinical cure and biochemical cure, and radiologically by doing diffusion-weighted imaging. Other options are combination of, just 1 slide is left. Combination of EDC map, combination of PET scan and MRI, or gallium leukocyte scan. To conclude, there is no adequate single modality to cover to diagnose this disease. A combination of functional and anatomical imaging is needed. High resolution CT is best for bone erosion. MRI is best for sensitive extension. Diffusion-weighted MRI 3 mm sequences with fat saturation and with gadolinium is advisable together with a separate high resolution CT at initial diagnosis, suitable for monitoring treatment response, suitable for decision to terminate treatment. Diffusion-weighted MRI and PET scan are promising imaging technique, but still their strengths have to be evaluated by further prospective study. Thank you so much.
Thank you, Professor Hisham. I shall introduce to the stage Professor Dr. Ahmed, Maher, Youssef. Is he in?
Hello, Dr.
Yes, please. Thank you.
Good morning, everyone. It's Ahmed Youssef. I'm otology and skull-based surgeon in Liverpool University Hospitals, and I would like to thank everybody for the invite, especially Dr. Badr, Din Mostafa. So this is obviously just a very short presentation about the NOE and the skull-based osteomyelitis. As we all know, it's an aggressive type of infection that can be quite lethal and can have some mortality if left untreated. And the reason for the importance of the osteomyelitis is because of the potential for causing significant morbidities, and especially that it happens in older age populations, and the morbidities can be paralysis of the cranial nerves, intracranial complications as meningitis or abscess. In England, we found that there has been a significant increase in admitted cases up to 10-folds, and as you can see, maybe in around 2002, there was only around 100 cases a year, but it jumped to 23 into almost 1,200 cases a year. And the probable reasons for that is that increase in the aging population, diabetes load, and also increased awareness amongst physicians as well. So we tried to look at the literature in our local cohort. This was a few years ago, and we had 29 patients. And as you can see from the slides, the average age is quite advanced, between around 82 years of age. Most patients were diabetic, but you can see that there is also non-diabetic patients, and we found that most of the, or all of the non-diabetic patients were above 80 years old, and which means that the advancing age in itself can cause or can be considered as an immune compromise. HIV patients were younger, and they were non-diabetic in most of the cases, and it's predominantly disease of males as well. As you all know, it's Pseudomonas that's the main culprit here, but also always consider the fungal etiology, especially in the immunocompromised patients, and Aspergillus is the most common. So there is about almost 20% history of ear trauma, and that's why we advise against ear syringing or ear wash in elderly population because of this. Again, the hallmark is the severe unrelenting otalgia, the otorrhea, the headaches, and the conductive hearing loss. When we see these patients, you find a normal picture of otitis externa, but it's more exaggerated. You can see a granulation tissue in about 72% of patients, but also they can present with facial nerve paralysis as well as other cranial nerves. In our cohort, there was about 37% of them presented with lower cranial nerve palsies. In terms of the investigations, there is an increase in most of the cases of the ESR, and it was found that it is actually probably more sensitive than the rest of the acute phase reactants. And I'm not sure why this is the case, but ESR tends to be high in these patients. As we all know, we try to get the culture and sensitivity from the ear, but there is a trend of growing, increasing negative culture because of the patients already have been treated by several antibiotics. Biopsies in these cases is quite essential because you need to rule out malignancy, but also we can use it to identify the organism, and in some cases you can do a PCR as well if the patient is not responding to treatment. As my colleague who just talked about the radiology, I'm not going to go through this again, but the CT scan, I would just say that there could be negative CT scan, especially early cases, because demineralization can take time. So it's easy to get the CT scan, and it's very helpful in early diagnosis, but always be aware of false negative early cases. The same thing that remineralization may never occur or can take quite a long time to happen, so CT is not enough or good for follow-up or deciding when to stop the treatment. MRI scan obviously is essential as well because it shows the soft tissue enhancement, the intracranial also problems, but again, it's not ideal for follow-up. Maybe with the diffusion weighted one, we've not tried this where I work, but the normal contrast MRI scan is not a sensitive tool for follow-up for these patients. The other kind of technetium ones, these are the old or the long-standing ones, the technetium and the gallium. And the FDG PET at our center, we started to look at this a bit more closely, and I'll mention in a second. So generally the treatment, we clean the ear out, we have to have a tight glycemic control, surgery, again, I think the next speaker is going to talk about this, but where I work, we don't really do much surgery apart from biopsy and maybe some removal of granulations tissue from the ear. Hyperbaric oxygen has been always suggested, but there's always been lack of enough evidence that it works. In general, we rely on the treatment of this potentially fatal condition on a long-term antibiotics. We use at least 6 to 8 weeks or maybe longer when we obviously use the anti-pseudomonal antibiotics, and we start initially with the IV and then shift to oral therapy. The oral therapy, as we all know, that is available for the pseudomonas is the quinolones. And the problem with the quinolones is that you need a high dose of ciprofloxacin or the quinolones, but there has been reports over the last few years coming up of a long-standing irreversible neurological side effects of them. So the question, I think, currently is when to stop the treatment for these patients. There is no agreed criteria so far, and if you undertreat, these patients would have a relapse, and relapsing in this age group could be, again, life-threatening. And if you overtreat, you'll get the side effects of the quinolones, and you are promoting antibiotic resistance. So there was a meta-analysis looking at 48 publications, looking at when to stop the treatment, and it was different strategies, including some improvement of the ESR, normalization of the gallium PET, and most studies used multiple criteria. The PET-CT that was alluded to by my previous speaker, you can see here that it's quite good in the diagnosis, but also you can see that the PET-CT can improve and tell you actually when to stop the treatment. We looked at our cohort, the second cohort that we looked at, it actually reduced the duration of our oral antibiotics significantly after adopting the PET-CT in deciding when to stop the treatment. So just a quick one, really, in terms of the prognosis. Some patients, as I said, could present with facial palsy, and most of the patients, 60% of them would improve. We've noticed that the ones that presented with grade 6 will never get back to grade 1, but they will improve. In terms of the lower cranial nerves, by about 8 months, again, most of them improved. So my key message is it's an aggressive, potentially fatal infection. Different investigations are needed for diagnosis and monitoring. Biopsy is needed and may need to be repeated as well. Pseudomonas is the main one, but always consider fungal etiology if no clinical improvement. A negative CT scan reduces the likelihood of the infection being NOE or skull-based osteomyelitis, but does not completely rule it out. CT and MRI changes last for a long time and may never normalize. Aggressive medical therapy can reduce morbidity and mortality. During follow-up, you need to monitor the patient's pain in terms of pain control, ESR, and further radiological investigations, and maybe MRI if there is clinical deterioration. A follow-up for 1 year is needed to make sure that no recurrence has occurred. Thank you.
Thank you, Professor Ahmed. Now we will invite to present his presentation Ms. Dr. Sampath Chandra Prasad. Is he in? Have anybody seen him? Okay. I have, may I invite Professor Ahmed and Professor Hisham to come to the stage, please, to start our discussion about the necrotizing otitis externa and skull-based osteomyelitis. And may I also invite Professor Ali Mahrous and Professor Baumgartner to the stage to join us for the discussion. Now we have different views, local and international views, to discuss this crucial, important. Professor Bilal, are you here? Could you join us, please? Please. We can't start any discussion about it without you. Thank you. My presentation here will give my presentation. I will give a very fast conclusion about these two important lectures we have listened to. In order to get to the point, to 4 or 5 important questions I will pose to our dear professors and panelists. Is it ready? Hey, first slide, please. Good. To summarize, I will not go into the history because most of us will be aware about it. The skull-based osteomyelitis, as you have seen now, is a term that is not yet clear. And there is no general agreement about the terms used in such conditions. As we have just listened to Professor Ahmed, he introduced necrotizing otitis externa. What does it mean? Is it different from skull-based osteomyelitis? Yes, it does. Because it is an infection of the soft tissue. Malignant otitis externa is no longer in place for such conditions because it is not, and it is quite evident, it is not a malignant disease. However, its behavior is a malignancy. I will not go into the anatomic consideration because it's quite obvious for all of us about the histology and the nature of the embryology of the concerned area. However, now we have to stop. With Professor Hisham, are you listening to me? Yes. When you put the diagnosis of skull-based osteomyelitis to certain patient, what's the criteria you depend on to say this is a case of skull-based osteomyelitis? Please, you have the microphone.
I was sent on that many so
Really, there is a very nice paper about the UK consensus about which has to standardize the criteria for diagnosis.
There is no sound from your microphone.
We have to differentiate between two things. There is possible necrotizing otitis externa.
Please keep the microphone as close as possible.
There is possible necrotizing otitis externa, and there is a definite necrotizing otitis externa. Possible, this is severe disease. We have to suspect it and treat it from the start. Possible, this means if there is severe otalgia, if there is evidence of granulation tissue or otorrhea in the external urinary canal, if there is nocturnal pain especially, and if there is one or more of the aggravating criteria, immune deficiency, Pseudomonas on examination, this is a possible type. And has to be treated medically at first, orally. If there is failure to respond after 2 weeks, we shift to another case. And for different diagnosis, I depend on radiology. As I said in my lecture, the radiology can document the presence.
Professor Hisham, may I interrupt here? Radiology is not as sharp as early diagnosis. Usually, the imaging you just presented.
This is what and we treat it accordingly. But for different diagnosis, I rely on radiology.
Professor Baumgartner, please, same question.
Yeah, it's a very good question. Actually, the patient never comes to you in your office and will say, I have a skull-based osteomyelitis. This never happens. So what we see is our three facts, and you mentioned one. all of our, or many of our patients have seen are diabetic patients, often poorly controlled and with a very high HbA1c factor. So diabetes is very important. Secondly, all of our patients have some case of immunosuppression. So this can be an organ transplant, this can be a rheumatoid arthritis, this can be a malignoma somewhere else, or a cancer somewhere else, which is treated very heavily toxically, or the patient had already another malignant disease in the head neck area with irradiation. So we have actually three main causes of this skull-base infectious disease. This is the diabetes or other hormonal problems. This is immune suppression and irradiation. And irradiation is very difficult because, in contrary to most of diabetes, for example, you will not find a bacteria. So in the irradiation necrosis, it's often, we call it a sterile osteomyelitis, so there is not a real agent in there, and nevertheless has this osteomyelitis problems, and in radiology it looks like this.
Okay, so the first question would lead us to certain fact. High index of suspicion in an elderly, poorly controlled diabetes with a history of minimal trauma to the external auditory canal and seeing some evidence of granulation and discharge in the external auditory canal with pain, recalcitrant, difficult to bear it over the past few weeks. Then, what labs would you advise, Dr. Bilal? استاذنا Dr. Bilal. What labs would you advise? What investigations are part of the imaging?
I think you're
Would you agree to this list?
you're listing a very good list for what we order, and obviously in a diabetic patient, the serum glucose to know whether he's diabetic really or not, or controlled or not. Then the rest are all things that shows you how you're going to go. Biopsy, let me comment on this part, because I've had a couple of cases coming in the last few months, and they were biopsied, and the biopsy was negative. But because that the patients were not responding to medical treatment, the extreme pain, the facial paralysis, they underwent subtotal petrosectomy, and they came up with carcinoma of the ear. So I want you to be very careful in those patients that you biopsy a small polyp or granulations in the floor of the external canal, and then they come with the cancer later on. So I think those patients who are not responding to your medical treatment, you have to go ahead and do an extensive surgery for them.
Okay, Professor Ali bin Mahrous. Your microphone, please, Dr. Hisham.
I want to add one investigation.
But keep the microphone close.
Culture before starting an antibiotic.
Okay.
Sensitivity for the organism. It's not listed here in the.
So, Professor Ali, once you raise the suspicion of skull-base osteomyelitis in a patient, would you present such a list on the same session, or in frequent sessions.
That is simply because the patient had been using antibiotics for a while. So, but I would follow exactly what you said, adding to the function sensitivity.
Okay. Yes, please, Paul.
So it's all perfect what my colleagues here said, but I want to point out
Still have time because we
it's
have
very important
presenter has
to have enough material for the lab. We discussed this many years ago. Some radiologists suggested, we just make a stereotactic puncture to the apex of the pyramid and so on. Please forget this. You really need to have a very, very good sample and enough culture material for pathology and bacteriology, because it is an infectious disease, and without identifying the agent or the bacteria, you cannot have no proper chemotherapy. So don't be shy, make a real surgery, a real access to get enough material.
Thank you. Now we come back to the imaging, and here I summarize over the next 3 slides the value of each of the imaging techniques available, or mostly readily available around in every governorate in Egypt. The CT scan. One major disadvantage, it gives you a delayed diagnosis of the skull-base osteomyelitis, because it needs demineralization of 40% at least, and this happens usually in at least 2 weeks, which is, in that course of disease, is very important. We depend on early diagnosis and early prompt management. And the MRI shows only the soft tissue. However, it also helps to determine the extent of soft tissue disease, not the bone involvement. The technetium 99. Technetium 99, it gives a hot spot when macrophages and osteoclasts get activated, so it shows up as a hot spot. But in course of the disease, if it turns into a black spot, inactivated, that means there is a sequestrum. Sequestrum means an important decision, helper for surgery. The Gallium 67, Professor Hisham has told us much about it. Here it comes to certain important issue. How would you grade the disease? Are all patients in the same grade once they had the label osteomyelitis of the skull base? Professor Gardner.
So
how do you see these 2 types of classification of the disease?
We need a new classification. Maybe we make an own conference about a new classification, because I think we have some new impacts. You should not forget, when Beneke had his classification done, CT was not widely available. We think about the year 1989. And Rehm and Kenny is already 25 years ago. And if we look what we learned in the last 3-4 years, since we have the photon counting CT, we learned a lot about the osteomyelitis as well. If I compare the old CT scans from the 2010s to the CT scans we had in the last 3 years with the photon counting, and look at these osteomyelitis patients, we see a big progress in the pictures, and I think this will help us in future.
Thank you very much indeed. Sorry, I could not have time enough to put forward 3 other questions to our distinguished panelists, so I have to leave the stage. Thank you for everyone. Thank you very much, my dear panelists.